Good afternoon, everyone, and welcome to our final CareNext Collective of the year presented to you by Manulife Canada. Throughout the series that we have started this year with the launch of CareNext, we've explored what it means to innovate inside complex systems, how to make progress in environments that are defined by interdependence, complexity, and care. And today's story really captures that beautifully. It is about ambulance offload times, something that might appear as a simple operational metric, but that actually reflects how we connect across boundaries, how information flows, and how trust is built at moments of transition. So when that handoff between paramedics and emergency teams falters, the consequences ripple outward. They cause delayed care, stretched staff, anxious patients. But when that same moment is redesigned collaboratively, performance and experience both improve. And so what we'll hear today is not a technical presentation, but really a story of shared accountability and learning and organizational and social innovation in action. So before we begin, I'm very excited and honored to introduce to you our speakers today. So first, Tricia Brown, Director of Emergency Departments at REN, who led this work day to day, translating intent into sustainable practice. Chief John Ritchie's Region of Waterloo Paramedic Services, a critical partner in aligning priorities across the system and building shared accountability. Wendy James, who is REN's Emergency Department Manager, who led the operational spread and adaptation across both campuses. Lakshmi Rajakumar, who's our member of our decision support team, who designed the data tools and dashboards that made progress visible and actionable. Becky Mueller, who's our patient partner, very excited to have Becky's perspective and lived experience that continues to remind us what these efforts are truly about. And last, but certainly not least, Brandon Douglas, our Vice President of Clinical Programs and Site Lead for Queens Boulevard Campus, who provided executive alignment and supported the enabling conditions for this work to grow. So really rich panel today. Each brings a unique perspective on how collaborative innovation happens in real-world conditions. To begin, I'll ask Tricia to set the stage and tell us how this work began, what challenge it sought to solve, and how the collaboration took shape. As ever, we will then go into an exchange. You will, as an audience, have the opportunity to ask questions. So I ask that you think of those throughout and leave them in your Slido chat. We will get some time near the end to ask those questions. And then just before we part for the rest of the year, we'll ask you to give us a little bit of feedback on the CareNext Collective. So with this, I would like to hand it over to Tricia. Tricia.
Thanks, Danina, and thanks everyone for joining. I just wanted to set a little bit of context for those that might not be familiar with the process. So ambulance offload delays occur when paramedics arrive at the hospital with a patient, but they can't transfer care over to the emergency department staff because there's either no treatment space available or staff might not be available. So during this time, the paramedics might need to remain with the patients, sometimes for hours, which means that the crew and the ambulance are unavailable to respond to other emergencies in the community. So just sort of on scale, Ontario has had some of the most severe offload delays in recent years, with paramedics waiting sometimes 2 to 4 hours to transfer patients. So at the beginning of our fiscal year, we had delays within our region at both departments of 87 minutes and 109 minutes. for each department. So we knew we had to do a better job for our patients, our staff, and for our EMS partners. So we started this quality improvement work. And for those who know, offload delays are usually a symptomatic problem of a broader system failure. And it has to do with inputs, throughputs, and outputs in the system. So it's really hard to stop the flow of patients coming into the ED. Although, work has been done to try to divert non-urgent patients or cases to other supports in the community. So care by pharmacists, primary care physicians, walk-in clinics, paramedicine, but, we can't close the doors when we're full. So the other issue is if we can't discharge patients quick enough or to get them out of the organization to alternate levels of care. So that could be retirement homes, long-term care homes, rehab, complex care. So we get backed up with patients on the inpatient floors, and that really slows down the flow in our emergency departments. But there are similar strategies in place and being worked on to improve these processes as well, not only in our facility, but across Ontario. Mm. So our quality group focused on the work of controlling what we can control, and that was the throughput through our ED and having narrowed down what we believe to be sort of our drivers and work to do some change. So we worked on optimizing our offload beds. This was working with the charge nurse and the dedicated offload nurse to try to change the roles in those areas. We worked on utilizing our offload beds differently, sort of as a horizontal waiting room in those spaces to try to decrease the length of stay. We went from 12 hours to 2 hours time in those spaces. And then working with our medical records to change the coding in the system to have them as waiting room spaces so that physicians and care providers would not be treating and admitting patients in these spots so they could be turned over quicker. And then we also did some work with our inpatient units and bed management to try to optimize and change our surge plan process so that we didn't have as many admitted patients holding in the ED that sort of limited our flow in the emergency department. So these are some of the ideas, but the ideas were easy, and really it's changing hearts and minds that was the real work.
Exactly. Thank you for that. And thank you for taking us through the process, because some of our audience members are not of healthcare. So thank you for explaining the process and how it works. To remind us why this work matters most, I'll now invite Becky Mueller, who's our patient partner, to share her brief reflection.
Thanks, Danina. Hi, everyone. So I'm Becky. I'm a respiratory therapist, actually, and worked in the region for many years. So I'm very well versed with exactly what Tricia was saying, the challenges with ER backlog and paramedics waiting to offload. So unfortunately, I had to be on the other side of the fence and use EMS services a couple months ago with my mother. She had a fall at home, unable to ambulate. So we had no way to safely get her to ER on our own. So we did need to call 911. The team arrived. They were able to get her on a stretcher. I asked if they could please take her to St. Mary's because they were a Cambridge crew. So they patched in and got approval, which was lovely of EMS to do that for us because all of her previous care had been at St. Mary's. So we followed, they left, we followed behind. I was anticipating what I'm used to, where they would be stuck in the hallway in offload and, so delay in getting treatment, diagnostics and treatment. But when I arrived, I checked in with the clerk and she said, "Oh yes, your mom's in here." She took me in right away. And I was shocked to see that my mom was already on an offload stretcher in the hallway being cared for, and EMS was already packed up and gone. So I couldn't believe it. And then I thought, okay, well, maybe we'll be stuck here for a while. But we weren't. So with, I think, maybe 30 minutes at the most, my mom was in that designated offload bed. And then a nurse came to tell us, yep, we're going to move your mom into in like a ER bed. So they got her into there. But even prior to seeing a physician, there was a clinician, and I don't remember, I apologize if it was the designated offload nurse or it was a nurse practitioner or someone else, but they got my mom x-rays right away, which so that expedited just timeliness to diagnostics and treatment. So she had a severe femur fracture, which if you're not a clinician, that's a very serious bone to break, and stabilizing that bone as soon as possible can impact the patient's outcome significantly. So with that timeliness to getting a bed, getting x-rays, and getting her leg stabilized temporarily was huge for us as a family. And then the other thing that it expedited was for the ER physician to be able to consult orthopedic surgery right away. So then that enabled my mom to have all of that care, ortho consult, and then a request for transfer to Grand River, where the orthopedic surgeon was, to be able to do her surgery. So say this all started around 2 p.m. in the afternoon. By 8:30 p.m., my mom was in an inpatient surgical bed at Grand River, designated to go down to the OR. So that was a dramatic change in what I've experienced as a clinician for years. So that is a huge, huge impact for me. So I thought it was a good idea to let your team know and your people know that it had real world impact for me.
Thank you so much for that testimony. This is why we show up to work and why we do what we do. And I'm so excited not only to highlight the wonderful work of this team, but also to share the how of it, so that hopefully we can influence others. So with that, maybe if we could go into understanding the underlying problem a little bit more. So Tricia, what was the tipping point that made it clear that offload delay was not just an ED operation issues, but a system-wide performance challenge?
Sorry, can you hear me now?
Yes.
I think we had tried to solve this problem many times in the past, and we just didn't have sustainable or positive results on making this change. So, we've had our dedicated offload nurse position and funding for a while. We've added more beds to the system. We've done lots of things to try to combat this. But it just hasn't stuck. And I think when we really did our root cause analysis with our quality improvement group, we realized that there's a lot of issues that are beyond the control of the ED. And I talked about that in the input and output. So we needed some help. There's lots of literature out there that points to this being a system-wide problem, and it's kind of beyond the region, the province, and in the country. All are struggling with the same issue. So we realized that we needed help from our inpatient floors, bed management, senior leadership, EMS partners. It takes the village to kind of move these things along.
Thank you for that perspective, Tricia. John, from the paramedic perspective, what were the early signs that the current model was no longer sustainable?
Thanks for the question. And Becky, thanks very much for your testimonial. It demonstrates to us why we do the work we do. So thank you. Really, this is going to sound like a bit of a weird answer to your question, Danina, but offload delays, as Tricia's already pointed out, is not a new problem in the Ontario healthcare system. It's been going on for 25 plus years. And for paramedics and paramedic service leadership and the Ministry of Health and hospitals, everybody knew that, excuse me, it wasn't an ideal state for patients in terms of their experience, but then also for all the providers that work every day to try and provide amazing, compassionate care to the patients that they serve. But in particular for the region of Waterloo, the biggest issues we were having was offload delays were a direct contributor to what we call code zeros, which is when no ambulances are available in the community to respond to a 911 call. And we track that quite regularly. And to give an example for everybody tuning in 2023, we had 132 different code zero events. And this year in 2025 so far, we've only had 5. So there's a direct connection there in terms of we improve ambulance offload times. We see a direct benefit to the paramedic response system. So it's code reds and code zeros. And then the other thing really was just the visual nature of you walked into a busy emerge department anywhere in Ontario, and regional Waterloo was no different, and you would see multiple patients on ambulance stretchers with multiple paramedics, and those were all ambulances and paramedics that were created and funded to go out to respond to 911 calls, and they couldn't do that when they were in the hospital. So it's kind of a weird answer to your question, but the problem is not a new problem. It's been going on for decades.
Thank you for that perspective. And I think what's important for our audience to understand is that paramedics cannot leave until the patient is being taken care of by discharged from the paramedics and taken on by the hospital. So from that perspective, John, how did your teams experience the downstream effect of the offload delay, not just operationally but emotionally?
Well, as I already mentioned, operationally, the code zero events were a really big metric and something that regional council was deeply concerned about. We also saw an increase in our response times to 911 calls because, again, if all the ambulances are at the emergency departments, they're not out in the community strategically positioned to respond to the next 911 call. And then what was a really important metric for us was we were seeing significant end of shift overtime where our paramedics could not go home on time. And, I imagine for everybody, imagine if your workday didn't end when it was scheduled to end and you were trying to manage your busy family lives and get home to get your kids home from daycare or whatever the answer was, it was really difficult for them. And then also during the workday, significant missed meal breaks. They didn't get the opportunity to eat a meal and take a break when they needed to. And so as a result, those operational issues created real wellness issues for our staff. And as I mentioned, if they can't go home on time and that's affecting their work-life balance, it creates real challenges for them. And we were seeing real impacts in that regard. And then also frustration for our paramedics was probably a big thing that was felt. I've said this many times before, paramedics did not enter the profession to provide hallway care in a hospital. They entered the profession to be on ambulances, to be in first response units, and to respond to people when they called 911. And when they couldn't do that, that created a big challenge. And then in particular for that, they would hear on their radios really serious calls going on in the community that they couldn't respond to for really acutely ill patients. So it created a whole host of issues. But the great news about this whole presentation today is we're seeing improvements in all of those areas. And so I would argue that our paramedics are feeling a much different level of wellness as a result of ambulance offload times improving.
Wonderful. So you mentioned something, in a very important perspective, which is the impact on the population. And we do have Becky here, not just to provide testimony, but Becky's a partner in this project. So Tricia, how did hearing directly from patient partners like Becky help sharpen the team's understanding of the human cost behind this problem?
Yeah, I just want to thank Becky again for sharing her story, sharing her family story, because that's really the impact. That's the why, right? And bringing that forward to our staff, the why should we care about this? Why is this important at this time? So, I mean, staff struggle every day with the limitations of the healthcare system, and it really weighs on them. And I think John brought that up as well. Everyone comes to work to do a good job and they want to help people. And sometimes the system, doesn't always support that. So it feels really good and rewarding when you're able to make a difference and make a direct impact on a patient or family's lives. There's just no better motivator in healthcare for anybody. So appreciate the stories. Unfortunate that your mom had to come and visit us, Becky, but I'm so glad that it was a positive experience.
You, Tricia. Lakshmi, what data helped make the problem visible and actionable across teams?
Yeah, I would say the data that really pinpointed the issue was actually the 90th percentile ambulance offload time, which was a metric that we submitted to the ministry each month. So the metric calculates the time from when the ambulance arrives at the facility to when the patient is transferred to the care of the ED team. And anything above 30 minutes was considered ambulance offload delay. And 30 minutes was also the target the ministry set for the province. And again, at one point with Queens and Midtown, we were well above 90 minutes. And it was happening both sides month over month. And ambulance offloads actually make around 22% of our ED total volume, so which is about 2,500 patients each month combined. So that was a very big number. That means that many ambulances were also being stuck waiting, and it was also affecting patient experiences. So that was clearly an issue.
No, well, thank you for that. I think it really nicely lays out the scope of the issue and the importance of this of the wonderful work that was done since. So in terms of that response, maybe a couple of questions as to the sort of the leadership and the roles and the realignment that took place. John, what changed when you started to see this is not a hospital problem alone, but a shared community system opportunity?
Thanks for the question. I'd like to start by saying that I think all people on both sides of this this solution, both in the hospital and paramedic services, knew that this was not just a paramedic service problem, not just an ED problem. We all knew that this was a patient flow issue. But in particular for my team, we knew that we could not solve offload delays independently or on our own. And we needed to participate in realignment with our system partners. And the importance about that is it was already, we had a good starting point in that there was already really strong relationships between frontline paramedics and the frontline nurses and the staff in the ED. And so I think the leadership group that's on this call today and others just built on those existing really strong relationships. And we shared a common goal that was about improving patient experience, number one. And again, Becky's story really resonates with us in that regard. But then also improving paramedic service resource availability to 911 calls, and then hospital inpatient flow issues. All those things together, if you can improve all of them, then we never want to see patients present at the ED or need to call 911. But when they do, we want their experience to be as smooth and as seamless and as compassionate as possible. And so I think those things helped. The other thing that is probably shouldn't be overlooked, and Tricia already mentioned it briefly, is that we did get an increase in funding for the designated offload nurse program for our region a couple of years ago. And that allowed us to spread out the designated offload nurse coverage from 12 hours a day, 7 days a week, to 24 hours a day, 7 days a week, which makes a huge, huge difference. And that's the other important thing for people to take away, is that ambulance offload times does not just occur on a Wednesday morning. It occurs 7 days a week, all times of the day. So I think those things became were real enablers for a shared system kind of approach to this.
Thank you for that, John. Tricia, what key design decisions set this initiative on the right path?
So I really think that having the right stakeholders at the table to identify the problem and offer solutions and feedback were really key on coming up with design solutions, and ones that that people who do the work kind of came up with, right? And so I think some of our just a couple of our design solutions were that horizontal waiting room that we talked about. So we had that dedicated offload nurse to provide support in the department, but it was changing how we utilized that role and how we utilize the allocated beds that were in that role. And so we had to kind of make a change in our electronic medical record system to change how we saw and how we utilize those beds. So I feel like that was kind of a big system change that had to happen, and a process and flow opportunity there.
Wendy, what was the significance of redefining the roles of the charge nurse and the offload nurse?
I think redefining both those roles just gave us more capacity to implement the project. So prior to this, the resource nurse would be like, it's the geographic location within the department, but the resource nurse or charge nurse, as most people call them, were sitting at the EMS hall at a computer station on wheels. they would start triaging one EMS, and next thing you know, there'd be 2 or 3, and they would end up stuck there until all of the crews were triaged. And then we would have the offload nurse in these stretchers, which we were using as another patient care area. So by redefining the roles, the resource nurse will sometimes be backup for the offload nurse, but mostly will be in the department, supporting the department. So as we've talked about, it's not just an emergency department issue, it's a hospital flow issue. So more actively checking in with the nurses to see, is there a challenge with getting patients upstairs, getting patients discharged, supporting and getting the resources that we need for flowing the department. And then also with that offload nurse, it's not a care area anymore. So that, if we can keep those stretchers empty, then, resource nurses include in right fairly quickly that now I've got an extra nurse to use as I need to until the next EMS crew comes in. So all of this is just, like as we talked about, increasing patient satisfaction, more efficient use of the resources. And so I think that, it was a win all around. And so I'm just checking. And so there was really, everybody felt good about how we were being able to flow the department once we sort of got there.
Thank you, Wendy. Brandon, what structural or relational supports were important to get the work started and to keep it moving?
Yeah, thanks, Danina. I think John alluded to some of it from the relational side. I think there was already a really good foundational support at the frontline level between paramedic services and the hospital. Several of us were new to roles when this work all started a year and a bit ago. And so, rebuilding and reestablishing and building off of those relationships that already existed at the level of those that are on this call right now, from a leadership perspective was fundamental. It also allowed us to set up a structure that was able to come together. We started meeting weekly at the beginning of this. And then as we started to see metrics improve, we started spacing out when those meetings were. But even to this date, we haven't stopped, because it's still important when we're looking at sustainability to make sure that we're still keeping our eye and making sure that there's any deviation, we're ahead of that very quickly. Because one of these, any kind of deviation from our performance or our processes could have a longer term effect if we don't get it back on track quick. So I would say from a structural perspective, having that group come together, and we really focused on the relational building piece before we started getting into changing process, really understanding each other at a kind of a human level. And, what is our experiences? We all come with different experiences. For example, I have a unique perspective in that I've worked at EMS services as well, and hospitals. And so being able to understand where all of us were coming from allowed us to contribute to the solutions in a very different way, but doing it together and collaborative and building off the strengths of each other. I would say also that from the relationship perspective, it wasn't just relationship with EMS, it wasn't relationships within the hospital, it was relationships within the community practice of emergency services across the province as well. So, huge shout out. We talked about wanting to shout out some key kind of enablers to here. Andrea Ennis, who's the director out at Humber River, who's had some huge success out there, looking to say, how do we emulate that? To John's point, REN isn't unique in offload problems. I've worked at numerous hospitals across the province as well, and it's a consistent issue that rears its head or spikes up and down for decades. And so being able to leverage some of the solutions that are already in place out there to similar problems and just tailor it locally was hugely helpful for us. So I would say leveraging internal and external relationships was probably a huge enabler for this project to move forward and to get the success we've seen.
Thank you for that perspective. And part of the reason also that CareNext Collective exists is built into design is the desire and to share experiences so that we can help share knowledge and build that collaborative community beyond just our region. Speaking of collaboration, John, from your perspective, what did the collaboration between paramedic services and the hospital look like in practice during those early weeks? And what helped you build trust and momentum?
I'm going to kind of add to what Brandon just shared in his response. I think it's important to recognize that before the project started, there was lots of important conversations done in a respectful and professional way between partners to get all the issues out on the table. One of the things when you have complex systems is sometimes it's hard to have difficult conversations, but I would argue this group really mastered that and knew how to have difficult conversations and say, hey, we're not doing okay. How do we fix this? And so it's a lot of relationship building or at least relationship strengthening. And probably the biggest enabler for us was when the Waterloo Regional Health Network leadership said, okay, this is an important priority for us. We're going to make this a priority not just for the ED, but for the entire hospital. That's when we started to see things really change. And that offload delays are going to be the exception, not the rule. It is a big kind of cultural shift. Not like there are other hospitals in this province who have figured this out, but I would argue that they would say to you the same thing. Once we culturally decided that offload delays were not okay in our hospital, that's when things started to progress. And then the other big enabler early on was the transparent sharing of data across the organizations. When we were able to show a dashboard and give them access to our dashboard of here's what our metrics are saying, now what are your metrics saying? Then we were able to actually compare apples to apples and actually make sure we had common definitions of things, even making sure that we all understood what transfer of care actually meant from a data perspective, what triage actually meant from a data perspective became very important. But kudos to the Ren team and to others. This was a big lift, and those enablers really helped us in seeing the improvement we've seen on our side.
You've highlighted something that plagues a lot of the sort of work that needs to be done but isn't in the world of disparate organizations. Having that seamlessness of data sharing is oftentimes one of the biggest barriers. And so if you could speak a little bit to kind of how did these two particular organizations overcome that challenge? Because we oftentimes see organizations not willing to share data and that halt efforts. And so wonderful to see that that wasn't the case here, but I'm interested in sort of what was behind that. How was that empowered and facilitated?
Yeah, it's a great question. Ultimately, I would say that it's because there's a coalition of the willing. I think that when you have willing partners who are willing to sit down and go, okay, I'm going to show you something, and then I'm going to give you access to it, became very helpful. I mean, I would like to shout out not just Ren, but also Cambridge Memorial Hospital in this work because they're part of this data sharing collection in our dashboard. They have all three hospitals have access to the exact same dashboard, sees the exact same metrics. And so that also creates it becomes a kind of almost a real-time report card. And people are in roles because they want to be successful in those roles. And so that report card helps them measure, are they being successful? Is the work they're doing having an impact? So I think that's part of it. Certainly at the Regional Waterloo, a shout out to our public health epidemiology and health analytics team, because they're the ones who created our dashboard for us. And then through them and our ITS system, getting approval to say, hey, we want to share this with external partners, and here's the level of data we want to share, and here's why. As soon as people said, yep, we can do that, it just created an enabler for success. Because I had been in systems, and I think everybody on this call has been in systems before, where the concept of sharing data across organizations became a barrier to improvement, not an enabler. And I think Ren and the Region of Waterloo said, nope, that doesn't work for us, and we're going to share this data. Now, we don't share individual patient data in these dashboards. It is aggregate data, but it does allow, for example, Wendy and her team to reach out to somebody on my leadership team if there is an individual outlier that requires kind of a more deep dive into that specific patient's experience, because we're all part of the circle of care according to the privacy legislation, so we can share this information anyways.
And I would add to Nina, I think that, sometimes as organizations, we create artificial barriers around being able to, why we can't share something. And sometimes that's because we don't want people to see it. And sometimes it might be because it's a lot of work. But I think in the spirit of this case, we were all hugely willing and I think needed to see what each other was seeing. A huge shout out to Lack on this call here, because she was instrumental in mining a lot of that data for us, because there was things we had no insight into, even how long a patient was sitting in an offload bed that wasn't tracked previously. And so even being able to share that with paramedic services to show here's all the things we're doing internally, I think was a huge contributor to trust building as well.
Yeah, I mean, this is what's going to build the future of care, exactly what we're talking about here. So I'm really glad that our region, Ren, and the paramedic services are an example, and Cambridge are an example. Tricia, on the sort of following the theme of kind of collaboration and joint workflows, how did clinical workflows between paramedics and ED staff shift during offload, and how did you socialize or train those changes?
Yeah, I think Wendy has spoke about this a bit too, and she would recognize this more being on the front lines with the staff and living it, and John also too with his team. But I believe it was just better interactions, less stress, less friction, more efficiency in the system. So it kind of lowered the temperature for everybody when you know the machine is working appropriately and things are moving and people don't feel as stressed. So I think, you know, we've heard it here. We were all sort of speaking the same language. We understood what each other's pressures were. You know, we all have limited resources and we all have challenges, but it's really just being respectful to each other and the work that all of us need to do, and realizing that we all have the same goal in mind, which is the patient and the family at the end. So I think, you know, EMS being able to provide us with the support and the funds for that dedicated offload nurse, and us being stewards to ensure that we're utilizing that resource appropriately for its intention, which is, you know, to get that service turned around back out on the road to support other patients in the community that need that support.
So Wendy, interested in your perspective, and also, you know, have there been any friction points that have emerged, and how did you resolve them?
Well, the short answer to that, Dean, thank you, is a lot of shoe leather. I call it walking out change. You know, in particular, that whole change back dynamic. A lot of our resource nurses have a lot of experience. And so, you know, letting go of a historic practice was a source of anxiety. And so there was a lot of reframing, a lot of supporting, you know, engaging them, like, here's what we need to do, you know. And I think I remember one particular, it was an impromptu meeting with 3 of the more experienced ones, you know, and through that meeting and able to guide them through some problem solving, they actually came up with a better solution in terms of how we're assigning the triage nurses, so that, because the offload nurse ends up assigning bays to patients, so they felt that they needed a more experienced person there. So I think that was part of the trust in the process, and just listening. Some of it is, I'm fortunate where my office is located within the department, so I can hear what's going on. We did have some early adapters who were like, yeah, we're going to give this a try. And there were a couple of late adapters, I'll call them, who, you know, every time I went out of my office, they would be triaging like the old way. And, you know, there's only so many times I can believe that the offload nurse is on break before I'm going to ask a question. And so just sort of giving that feedback and you know, asking them to help me to understand how they were feeling. So that was part of it, you know, focusing on patient safety, community safety. And then another source was like when it was high census in the department. So again, we could have maybe have a lot of patients admitted, no beds, or just a high volume day. And the physicians would be concerned because there'd be no new patients to see. So their first go-to would be to use those offload stretchers as inpatient surfaces. And so making analogies with the main waiting room, like if this was in the main waiting room, would you have a doctor go out and see the patient? So I think that, you know, the reframing that way to normalize what the expectation of that horizontal waiting room was. And then Tricia alluded to the technology that we use within our electronic health record, where doctors couldn't see patients when they were in this horizontal waiting room. Now, if that patient condition deteriorated, there was a workaround to get the doctor to see the patient. And really, it was just sort of developing that trust with the patients, and then, or with the team. I think, again, speaking of trust, through the organization, when we're talking about organizational engagement, the surge plan, you know, seeing that surge plan in action, and then there's an offload escalation process that starts. We ask the resource nurse to let us know. So Anyway, when we needed to escalate that, I would make a point of connecting with whatever key stakeholder I needed to in front of the team so that they could see that those processes were more than just pieces of paper we have posted in the back hallway, that they could see them in action and then see the benefits or at least get a response from it. So I think, there was a lot of work that way, which eventually helped with some of those friction points. But, in terms of like cleaning or TOC, all of that sort of went on quite smoothly. It was mainly those pieces. And then I guess John too talked about sharing data, sharing information. What we heard a lot was we can't see what's coming in. And so they wouldn't know where to assign beds to from the main waiting room versus the offload waiting room. So through the support and through the collaboration with EMS, we have a screen up in the back hallway now where this computer on wheels is that shows first watch, so they can see which crews are on their way in. And so that has been very helpful in both the resource nurse and the offload nurse in planning their workflows. So I think, we were successful in addressing a lot of those friction points to people's satisfaction.
Unsurprisingly, what comes out through for me, it's collaboration, communication, data, right? So speaking of data, Lakshmi, it was mentioned now several times, the importance of data sharing, the role of the EMR. So can you speak to us a little bit to kind of the core metrics that were tracked, and how did you select ones meaningful to both sides? And then also the role that the EMR and digital workflows play in reinforcing accountability and shared insight.
Yeah, for sure. Again, the core metric that we were really tracking was in 90th percentile ambulance offload time, which was a metric that we submitted to the ministry. So it was very important for us. And this initiative was aimed at targeting that metric. And after implementing the horizontal waiting rooms, we thought it was useful to track the utilization of these beds. So I created a dashboard that tracked the number of patients in these beds, breakdown of these patients by their CTAS levels to look at their severity of the cases, their average time in these beds, and the total hours. So these total hours were the hours that we actually saved, which otherwise the patients would have spent in the ambulances. So which was very important and key for the paramedics to understand and for the ED team. So just to give some context, last month we had about 450 patients and we saved around 1,000 hours. Those 1,000 hours would have added to our metric and would have affected all the patients in the ambulances. In terms of the EMR, we were lucky that both the hospitals were using the same EMR system when the merger happened, Cerner. So we were able to leverage it in creating these horizontal rooms where the ED team could choose where the patient was being placed. And the data was also stored in the same data warehouse. So I was able to create dashboard using these data and in real time. So we're at a point currently, a report gets sent every morning to the ED team of patient level data until yesterday. So now the ED team can look at the patient level data and see if there's any issues or any discrepancies. They're reaching out to the paramedics right away and the issue is addressed.
Thank you, Lakshmi. So, behind a lot of what we were defining in whether it's data sharing, communication, or collaboration, is the culture, and culture has to be built and sustained. So I'd like to spend a couple of minutes diving into that. Maybe, John, from your perspective, what trust building was required to create a meaningful partnership between paramedic services and the hospital?
That's an interesting question. And for me, when I joined the region of Waterloo, one of the things I was immediately positively struck by was that the existing relationships between frontline paramedics and the emergency department teams was so strong. And you could see that charge nurses and paramedics maybe had different perspectives, but were equally frustrated about the issue. So that for me creates a kind of a foundation of trust, even though everybody knows the difficult conversations are coming and who owns what and things like that. But so to be fair, I'm not entirely, one of the enablers here is we didn't have to spend a ton of time in actually building relationships. There were a couple new players at the table which had to get up to speed, but there wasn't a ton of trust building going on. I think because it was already there. shout out to the, almost 400 staff and paramedic services and the work they do every day. But they would tell me, they were very, very blunt about what was working and what wasn't working when I would meet with them, which made it very easy as well. And then they were also the first people to say, hey, I got off on time for the last 3 shifts in a row. And I know that that's because I also wasn't on offload delay or for any of those 3 shifts. So it created I think from a trust building exercise, when we started to not only see the data improve, but also see the qualitative experience of the healthcare providers and the patients improve, that's when everybody went, hey, this is working and we can trust this and we need to keep going. And we actually, I would argue, everybody in this call doubled down on the initiative. And, there may have been some hesitant people early on who went, oh, we'll see if this works. But then as we started to see it work and as we started to see real sustainable improvement, it genuinely is an exciting thing to talk about every couple of weeks when we meet and we go, hey, this is really working for us. Is it working for you? Yeah, it's working for us too. So I think, I don't know if that really answers your question, Danina, but there was a strong foundation to begin with. It was just making sure that we took care of that foundation and sustained it over a longer period.
Thank you. Maybe now from the sort of the hospital perspective, this I think goes out to Trisha, Wendy, and Brandon. How did your teams respond to changes? What is your sort of take on the culture and trust building that is required to create a meaningful partnership like this?
Yeah, it's always difficult. Change is difficult. Nobody likes to do it. It takes you out of your normal routine. It kind of sets you back on your feet. It takes a little more time to do things initially. So it's really working on that resistance piece, people resistant to change. And Wendy alluded to, people wanted to slide back into sort of old process and say, well, we can make it work the way it is. And it's just constantly keeping people on track with what the process is, reminding them why we're doing it, showing them the data of not only, hey, look at the positive data of the great things we're doing, but hey, look at on a day or on a time period when we didn't follow the process and look at how it negatively impacted the system. So it's really offering them the proof of it working or of it not working. And to John's point, like there's that buy-in, they're kind of waiting to see, oh, sure, it's another quality improvement project. It's another something we have to do. But I think, I think there was buy-in early, and then you got your late adapters later, who could see the proof in the pudding, could see that it was really making a difference. And it's really just staying on top of it now, because we can't let it slide. We can't, let the gap become big, and it's keeping people on track with what the process is and the gains that we've made.
I would add, Danina, I
Go
think
ahead.
yes, sorry, I think that as well, that the culture, not just inside the ED, has been impacted by this, but outside the ED. So these performance metrics, we'll call them, and experiences that our patients are having are shared daily at our bed meetings as well, where all of our frontline charge nurses are there on the inpatient sides, and they're hearing that the impact of them, with their great work on patient outflow from the hospital has actually positively impacted the metric from the day before. So it's almost a real-time realization that, there is the why behind what we're asking them to do as well, appreciating it's a hospital issue and system issue and not just an emergency department issue.
Have they been involved, and sort of had a sense of ownership of the process redesign itself? Brandon, Trisha, or Wendy, or all three of you?
Yeah, I would say, I think at the organization level, I'll speak to in terms of surge planning, development, and all of that. I think there's multiple inputs from stakeholders across the hospital. Again, really appreciating and understanding the why. We might not have a lot of admitted patients in the emerge, but we could have got, 6 or 7 ambulances come in a very short period of time. And so we might have to open up an unfunded bed here or there every once in a while to really support that flow through of patients, appreciating the why behind various triggers to open additional capacity in the hospital beyond the historical, when there's X amount of patients holding the ED, we open up beds. We've created multiple reasons and methods to open up additional capacity, appreciating the substantial impact it has on the community.
Wendy, from your perspective, how do you see this day-to-day collaboration between paramedics and ED nurses sort of evolving, and especially when things are working well?
I think as everybody's alluded to so far, there was a pre-existing rapport between the ED nursing team and the paramedics. But I hear, and it warms my heart to hear that joviality and, we'll see you again soon as they're leaving. So I think that collaboration has only served to strengthen on both sides, but also the job satisfaction. Like John said, we don't have paramedics, trying to sit for hours in a very uncomfortable folding chair and nurses trying to work around it. So I think that's been key. And just, earlier you asked about the culture change, and I had one of the late adopters actually say to me just the other day, she was speaking with pride and, how hard the change was, but basically was embracing the change now. So that's the reward for all the hard work. So, and I'm sure if she's feeling that way, there's others. So I think that, we've only gone on to strengthen the rapport. And I think there's that mutual respect as well.
Can you speak to what was hard about the change? And if you have any perspective on how it was overcome?
Well, the change was hard for the team, especially those with a lot of experience in giving up old practices that they felt had served them well. And I call it going nose blind, because they couldn't see that we needed to adapt to the new flow. Like, we're seeing a different patient population, higher volumes. And so on a personal level, that really hurt me, because I could see the anxiety. I knew we needed to change. And so how can I support them? So it was a lot of listening. And then, and putting it back to them and making analogies, right? If this person came in the front door, would you be calling for a stretcher, right? These are the ones, so, chest pains. And I think Andrea Ennis, who we spoke about earlier, used this analogy, two people with the same symptoms, one comes in the front door, they sit in the waiting room, the other one comes in by EMS, and we leave them on the stretcher. So again, just helping the staff to see that, making those analogies and just sort of reevaluating some of these long hold beliefs that were no longer serving us well, that we've outgrown.
Thank you for that perspective, Wendy. I mean, time has just flown by. This is such an interesting and rich discussion. Thank you so much for sharing the depth of this the reflection and the process that you've gone through. Maybe we'll continue talking, and then audience, we're inviting you to put in any questions if you have them in Slido. I'd like to get back to Becky now, maybe building on what you shared earlier. How have you seen or felt the patient experience shift as a result of this work?
It's a great question. I think one of the things, and I think John alluded to it too, is just the moral distress that clinicians feel, whether they're paramedic, or I'm an RT or RN, the physicians. When you're working in a system where you feel overwhelmed and you see patients that need care, but you just don't have the capacity to do what you need to do, the patients see that and feel that, right? And as much as you try to hide how overwhelmed you are, patients pick up on that. So even that time with my mom, I could see a change. Like, the staff just seemed more upbeat. They didn't seem beaten down and exhausted. And having experienced that as a clinician, that really spoke to me, to see how, oh my God, this nurse was just so bubbly and happy and excited that she could get my mom to x-ray right away, right? Because it's, you sign up to do this job to take care of people. So now when you have the tools and the capacity to do so, that speaks volumes, and the patients feel that. So I think that alone was a huge impact for me that day with my mom. And I know, and if this is something that can be done daily, that's going to have a huge impact on patient satisfaction.
Thank you. Tricia, can you speak to how might patients and families be more structurally engaged in flow work across the system?
Yeah, I think at RAN and at most organizations, there's usually a patient and family advisory committee. And we have that within our organization. And we have a couple patient and family advisors that work with us on our quality improvement projects. We run things by them when we want to update things on our intranet page, how would they like to see them, what makes sense to them. So it's really key and important to get those perspectives, and they ask different questions from a different lens, which causes you to pause and think about things differently. So, really anyone can be involved. Get in contact with any hospital near you or organization. We have surveys that go out for patients and families, and so we follow up on those survey results. Patient relations, you can have, submit compliments and complaints if there happens to be any. And again, we follow up on all these things, and you can obviously always advocate to your local, parliament members or region or province, but, really just contact your volunteer association within the organization. We so value that input in all of our projects.
Thank you. Thank you, Tricia. Brandon, how does this work prepare us for what's ahead? More volume, staff shortages, or upstream diversion programs?
Yeah, absolutely. I think, at REN, we're absolutely well positioned for this, appreciating where we are in our journey to a new hospital and expanding services across the Waterloo region and those that we serve in the surrounding regions. And so, we've been fortunate, again, leveraging those relationships we've had to be part of influencing even the 10-year master plan at Waterloo Region Paramedic Services with John. We had a seat at that table to really show how our work in this space can actually influence their long-term plans around where do stations need to go now? How many paramedic crews do we actually need on the road in the future? When we look at sustaining this work, we talked about it not just as an ED problem. Of course, we know volumes year over year continue to go up. The acuity of our patients and the number of conditions they have continue to increase as well. And we know that's not going to get better. And that's going to be a metric that continues to climb well beyond when our new hospital opens as well. And so I think fortunate as part of the process of building the new hospital, we're working on what capital redevelopment and reinvestment and what does kind of our coping strategy to get us from now until our new hospital opens look like. And all of that will impact how we're able to sustain this work because we appreciate that it means how do we care for patients differently. Working with, within our new strategic plan that will be released next year. And, a huge fundamental piece to that will be looking at diversion opportunities and care closer to the point of need so that when you call 911, maybe you're not actually getting an ambulance. There may be a care team that shows up to your house or, you're not admitted to the inpatient unit on the hospital anymore. We're admitting you to your home where you're a lot more comfortable. Healing is experienced a lot differently with very different enablers. So super excited about the work we have ahead at REN as we work on our new strategic plan that will launch next April. And a lot of that is embedded in that. So we can sustain what we're doing now.
Thank you. Thank you for that. And, CareNext innovation team is very excited to be supporting the organization through this amazing endeavor. John, what guidance would you offer to another region looking to start a similar initiative like this?
Yeah, great question. I think one of the things that's been highlighted in this conversation is how important data is and how important not just collecting the data, but analyzing it is. Lakshmi talked about the saved hours that she tracks. Those saved hours, although they track it as a metric in the hospital for performance, it directly impacts our ability to get funding for the designated offload nurse program because that funding from the province is based on performance. The better you perform, the more sustained your funding is. And so those saved hours demonstrated that, hey, the money that the province is investing is worth it. The other thing is to not lose sight of the qualitative. Data is all very important, but it's really important to hear Becky's story. It's really important to hear the stories of the frontline nurses and the frontline paramedics and patients and their families. And then the other last thing I would say is commitment to regular engagement with your partners. We all prioritize a bi-weekly meeting, and that becomes important. Sometimes a few of us can't attend, but the teams still meet. And that really allows us to make sure that if there is a bad day, we know, okay, yeah, we were already on top of it. We know it's a bad day. Yeah, Monday was bad. Yeah, it was. Okay, did we fix it? Yeah, we fixed it. It's not bad anymore. So that becomes really helpful. I would suggest that, you absolutely need to make sure from a paramedic service perspective that hospital executive leadership prioritizes this as a quality improvement initiative. If this was just frontline paramedics and just frontline nurses trying to improve something, there wouldn't have been as many enablers for success. So kudos to Brandon and Trisha and their teams. They prioritize this, and that's one of the reasons we've seen this amazing improvement.
Thank you. Thank you so much for that perspective. I'd like to conclude with Becky. And then we'll go to a quick poll just to get some of your insights about what's next for CareNext Collective. What would you like to see next for CareNext Collective as we conclude this final session of 2025? So Becky, what message do you hope today's conversation sends to other patients and families and regions, who have experienced long waits or uncertainty during transitions in care?
I guess the message I just want to say is working together and collaborating with the community partners. It works, and the work is hard, but it has direct impact on people. And I was able to experience that personally. And seeing that firsthand, it just shows that, everyone's tired coming off of COVID and, and starting new projects and moving forward. And there's always going to be challenges, but just please make the effort to put the work in, because it pays off. It's hard, but it works, and it has a significant impact on patients, and not only patient satisfaction, but actually real patient outcomes. If my mom had a longer delay in getting her femur stabilized, she could have had a very different outcome. And laying on a stretcher in an offload hallway where the paramedics are limited in what they can do, that would have significantly delayed her care for hours, and she could have had a poor outcome. So I think the work is worth it, and we have to do it. So thank you. And thank you for everyone that put the effort in to make this great for my mom. And I know it gives me confidence as a member of this community that if I ever need to go to ER for myself, I feel so much safer, right? So it just gives me confidence that the region is working to do things that are great for patients.
Wonderful. Well, thank you. Thank you. And thank you to each of our speakers for your insight, for your openness, and thank you to our audience who joined us today and who kept joining us and supporting us from the very launch of CareNext Collective. The story reminds us that innovation in healthcare begins not with technology, but with trust, with people who decide to learn together across boundaries. As I've said, we'll pause in December and return in January with new themes, new stories. So thank you for sharing the ideas with us. We'll heed them. We are looking forward to continuing with you with renewed purpose. Wishing you all a season of rest, of connection and reflection. And I'll end by thanking our presenting sponsor, Manulife Canada, for allowing this platform to exist. Thank you all.